unmute.
Yes.
Yes. Buenos días, estimados amigos. Vamos a continuar el curso el día de hoy, viernes 24, con tres temas muy importantes. Primero, el ultrasonido del tobillo y pie, conferencia a cargo del doctor Yuhani Koski. Luego, dos conferencias muy importantes, ultrasonido de la espondiloartritis, evaluación de la centesis. Y el tercer tema, el ultrasonido de la enfermedad reumática sistémica. Después después de la conferencia de ultrasonido tobillo y pie, el doctor Santisteban va a realizar una introducción de los aspectos clínicos básicos de las espondiloartritis y enfermedades reumáticas y el rol del ultrasonido. Bienvenidos, ¿no? We continue to the course with three very important topics: ultrasound of the ankle and foot, ultrasound in spondyloarthritis, evaluation of enthesis, and finally ultrasound system rheumatic disease. After the ankle and the foot ultrasound conference.
Hola doctor, ¿cómo está? Buenos días, doctor Ramírez.
¿Cómo está, doctor? ¿Cómo está? Estamos iniciando nuestra actividad. Mencionaba que en primera instancia el doctor Yuhani va a hacer la evaluación del tobillo y pie y luego dos temas importantes, ¿no? Como habíamos mencionado. Y al final la mesa redonda, pero previamente el doctor Santisteban hará una introducción de los aspectos clínicos. Adelante, doctor Yuhani. Thank you very much.
Thank you very much, Mr. Chairman. Greetings from Finland. Now it's afternoon, and I think you have early morning. Yes, okay. So we are running through these joints, how we can use ultrasound in different joints, and now we have the topic ankle and foot, and ultrasound offers wonderful things for that. Again, I will recommend these EULAR web pages if you want to learn very good way to how to depict normal joints. There are more than 300 images and videos from ankle and foot, but not pathology, but normal joints and tendons and so on. Here are some images from these presentations. So, and also to remind you that we can depict very many pathologies using ultrasound in joints, tendons, and so on. But I will not read these. We go through this in a few minutes. Let's take the very common clinical problem. Patient seems to have swollen ankle, but is it really? Is there only subcutaneous edema? Yes, in this case, there is subcutaneous edema, and ultrasound offers very rapid solution for depicting this. You see this black thing in subcutaneous tissue. It's very rapid way to solve this problem. A second example of extra-articular swelling is the very common phenomenon, especially in elderly or middle-aged women. They have, especially during day, increasing swelling in the ankle area and in the lateral side especially. And ultrasound can show very easily that it's fat, and because of gravity, fluid accumulates in this fatty tissue, and so it's a easy problem to say for the lady that this is not arthritis, it's only extra-articular tissue. Now we start to scan ankle Very good landmark and good way to start is the upper ankle joint, tibio-talar joint. And you put the transducer and always not just in the middle, but you have to move from medial to lateral, from proximal to distal, always to find pathologies. Usually there are some tendons, for example, in this case, extensor hallucis longus, which is in this middle panel image here. What you can see, you see tibia, and then you have talus, neck of talus. Again, the same using skeleton model, how your transducer is located. And in normal case, you see just fat on the talus, something echogenic material, and probably cartilage on the. And in case you have effusion, you see a black area on the talus. The fluid displaces the fat upward. Always, it's easy to when you're scanning the tibio-talar joint to move the ankle like this. If there is some little effusion, for example, in normal joint, this area does not change much. Like here, you see there is no change at that area. But in case of small effusion here, you see that here, a small effusion can be found using this extension and flexion movement. So ultrasound always offers us a dynamic way to examine. I will talk in day 3 more about crystal diseases, but in this case, but here I show this double contour sign, which can be found on talus. You see here bone, and there is a double sign here on the bone. So this is typical for gout, but we will come on this later. Then we have a second important joint in rheumatoid arthritis. This is the subtalar joint. And in this case, I'm showing here the so-called posterior subtalar joint. How can I depict that? We put the transducer like this and fix it in front of lateral malleolus. And usually we can see in normal patients very well the joint cleft, and in case of effusion, you see black area near the joint. And again, dynamic scanning is good because inversion movement makes it more clear to verify the joint cleft here. As you see in normal joint, again, there is no, there is only echogenic material fat here. But in case of arthritis, you can see something more. You can see fluid, and this is not quite black. It means that probably it's synovitis, which can be verified with Doppler, because in chronic arthritis, there it grows vessels here. Subtalar joint, as I said, usually I scan it using this lateral way. This is the corresponding image we already saw. But you can also scan it in the medial way using medial scan. But usually this is much more easier way to scan, I think, the subtalar joint synovitis. Here is a grayscale image, a huge chronic proliferation coming out from the joint with Doppler signals. A lot of vascularization confirms the synovitis in the subtalar joint. When we move medial, there are important structures: tendons, tibialis posterior tendon, then flexor digitorum longus tendon, and but hallux, flexor hallucis longus is more far away, and it is a little bit tricky to find with ultrasound. We will come on this later. There are so-called memory rules to remember for those who don't use these, who are learning Tom, Dick, and Harry. So tibialis posterior, flexor digitorum, and hallucis longus. But there are also between these structures two veins, artery, and nerve, tibialis nerve. It's not posterior nerve, like said here, it's tibialis nerve. Using this approach with transducer, you see this kind of image. You see tibialis posterior, flexor digitorum, and much more down is Harry or flexor hallucis. It is covered by so-called sustentaculum tali. I will show a better image in next slide. Then we have a deltoid ligament. Very thick ligament is here, and tibialis posterior tendon is on the deltoid ligament. And here, this is the subtalar joint, the anterior aspect here between these bones. Just an example of arthritis, chronic arthritis around. There is widening of the tendon sheath with proliferation and Doppler signals in around tibialis posterior, around flexor digitorum longus. And you see the position of transducer always here. Grayscale and power Doppler of tibialis posterior tendon. That was in long axis and now in short axis. Grayscale and Doppler. Doppler is very nice imaging modality because it verifies very often the inflammation. Of course, you can say here that there is a fluid, but if you push the color button, it makes it more real and more reliable, the inflammation. Sometimes you may also in rheumatological practice find something not so common, because in healthy people, tibialis posterior is located in this bony corner, but in this case, the tendon was luxated, and the patient had problems. So there's a retinaculum rupture around the tendon, so it luxated over the bone. Now, the hallucis longus. We see here the so-called sustentaculum tali, which is here in this lower right panel. It is a protrusion of bone that keeps fixed the tendon here. This is important, but because of this bone, it's sometimes a little bit difficult to find in normal case. In this case, you see here tendon and really huge expansion of the tendon sheath. So you see here the synovitis. We have a closer image here with Doppler. Doppler confirms the synovitis. Injection of this hallux longus is a little bit tricky because, as you see here, tibialis nerve is just around on the. It's a little bit complicated to put the needle here. You have to be careful. In long axis, the same. Tibialis, flexor hallucis longus, tenosynovitis. Now we move to the anterior ankle. Now again, the memory rule, Tom hates Dick. This means tibialis anterior, extensor hallucis longus, extensor digitorum longus, in that order. And we use usually transverse scan. Of course, you have to go proximal, distal, and also use longitudinal scan if you find some special lesion. Here you can see some pathology concerning tibialis anterior, and here is it says enthesitis. You see here the medial aspect of the attachment of the tibialis anterior, and the patient had painful area here. It was enthesitis at that specific area. Sometimes also rheumatologists might hit traumatology, and in this case there was a rupture of tibialis anterior tendon. You see the stump of the tendon here. The connection to the bone was cut. We move now to lateral side. We see here the peroneus tendons. Here we have the longus, which is usually lateral, and the medial against the bone is the short brevis tendon. And again, if we have the tenosynovitis, there's widening of the tendon sheath with the black area around it. It is fluid, but also you may realize that there is mixed echogenicity, and if you put the Doppler, you see a lot of circulation in this tissue. It means chronic tendinitis in the peroneus system. Enthesitis of peroneus brevis can also be possible. This peroneus brevis attaches to the proximal end of the fifth metacarpal bone. But we will talk about more of these enthesitis systems later. You might sometimes also hit a rupture of the peroneus brevis. This patient was sent for a rheumatologist for suspicion of arthritis, but no, this was the reason for the swelling of the ankle was rupture of peroneus brevis tendon. You see in long axis discontinuity probably hematoma here, and in short axis, you can't visualize only the remnant of the tendon. You sometimes may hit a third peroneus tendon. It is the tertius. The frequency is from 5 to 75%. It's depending the population studied. I think in Finland this is not very common, but you see here the corresponding ultrasound. It attaches to the proximal fifth metatarsal bone. If the patient has this stabilizes more the ankle than in healthy patient who doesn't have this. So this is a good thing to have extra. Okay, and the posterior ankle. The most important finding is to depict Achilles tendon. We will come on this in a minute, but I just show here that under the Achilles tendon there is a so-called Gauger's fat here, but you can also in most cases depict tibiotalar joint and subtalar joint here using this posterior approach, but we don't usually need this approach for detecting fluid or synovitis in the subtalar or tibiotalar joint, because it's enough to depict it in the anterior area. Now the Achilles tendon. Ultrasound is the best imaging modality to depict Achilles tendon. We have a very high pictures, very good pictures, the resolution, high resolution images. We can depict tendinitis, peritendinitis, enthesitis, ruptures, partial or total. We see the enthesitis, of course, we don't see what's happening in the bone itself, but everything else from this tendon. Normal Achilles tendon is about 5 millimeter echogenic tendon with fibrillar structure in long axis and in transverse, this ellipsoid kind of thing. And it does not have usually Doppler signals. The exception might be athletes who have just have a 10-kilometer run or so. You might see some Doppler signals, but not in healthy healthy people who have no activity before the study. In case of tendinitis, you see swollen and the echogenicity has gone down. It's because there is fluid. This is typical mechanical tendinitis compared to the normal, which is looks like this. So this is mechanical or degenerative chronic tendinitis. Again, image to show tendinitis with Doppler signal. In this case, the Achilles tendon is more than 1 centimeter, more than 10 millimeter thick. Just Doppler image, grayscale, and with the normal side, and this is the corresponding diseased site. Peritendinitis of Achilles tendon is not very common. This is the pathologic case, here is the normal case, but sometimes you may see this. You see there is some dark area on the Achilles tendon. Well, there is also Achilles tendinitis because there is some Doppler signal, but the most relevant finding is echogenicity. It goes down and there is Doppler signal. And now we have a transverse view. There is an echoic area around the tendon with Doppler signal. This is peritendinitis. Achilles tendon doesn't have synovial tissue like flexor tendons in hand, but there is a peritenon, paratenon that can be inflamed too. And then the Achilles tendon rupture. We see here gap between distal end and proximal end. And a video. Now this is the distal, this is proximal, and I'm moving the ankle. You see, there's only the stump of the tendon here can be seen. Probably there might be some fibers attached to the proximal side, but in practically this is totally broken. We also might have partial Achilles tendon ruptures. The location is usually here in the myotendon junction. For example, middle-aged people who are playing tennis, they feel sudden pain at this area, and the echographic finding is not so clear. You might see some swelling, corrective Doppler signals, and so on. And on the skin there is hematoma usually. Okay, but this is a partial rupture. And enthesitis, we will talk more about enthesitis, but now we just here see here is a bursa. And there's something strange here. It's a large erosion with Doppler signal in calcaneus. We will talk more about this enthesitis system later. And the retrocalcaneal bursa is very easy to depict with ultrasound, and also the injection is very nice and easy to perform here in the bursa. Chronic bursitis with a Doppler signal here. We move to the plantar fascia. Normal plantar fascia is very easily to, we can depict it very easily. It's about 3.5 millimeters echogenic fibrillar structure. And in case of fasciitis, it is swollen, it changes more dark, anechoic, and it's getting thickened. In chronic cases, there might be seen also spore. Ruptures of plantar fascia, I don't have an image of total rupture, but in this case, this patient had so-called split in long axis and here in transverse, but this is not quite common. In athletes, this can rupture totally. Then we have so-called plantar fibromatosis, sometimes to be recognized. It is the fibromatosis attaching to plantar fascia at this point, shown in this cartoon. It's something same than Dupuytren's contracture in palmar side, something related phenomenon. Rheumatoid nodules can be found sometimes, especially at that area, and this is very nice to inject with needle. With ultrasound, it is also nice to examine these ligaments of the ankle. I'm not talking about this very profoundly, but just to show that the most important ligament to get injured is fibulothalare anterior. We have the syndesmosis fibulotibial ligament, and also talocalcaneal ligament in the posterior area. But with ultrasound, it's quite good to test these ligament fibulothalare anterior to make the stress test. You see here the ligament in this video, and it's healthy, not torn. The transducer position is seen here in the upper right panel. The mid-tarsal joint, there is a lot of joints here in the mid-tarsal area. And it's the most easiest way is to take the landmark of tibiotalar joint. And then the first joint is talonavicula. And then we have the navicula cuneiform. There are 3 cuneiforms. And just to start from the tibiotalar joint and then go distally and try to find these clefts. This is the way to, and of course you have to learn anatomy and study and to get to know them. It's the extended view of these joints. Tibiotalar. The first is talonavicula. Navicular bone is here, and cuneiform is here. Navicular cuneiform, and the first tarsometatarsal bone. In case of arthritis, there is fluid or proliferative tissue in these very small joints. But especially this talonavicular joint is very difficult to diagnose the synovitis clinically, but in ultrasound it's very, very nice. Here is a small talonavicular joint synovitis with Doppler signal. Also, we have here calcaneocuboid joint here and synovitis. This is not very common, but also one small joint that can be inflamed. In this video, you see a clear tibiotalar joint synovitis. In this case, we don't have Doppler signal, but look what's more distally. There is clear, a huge talonavicular joint synovitis with Doppler signal. This arthritis is not easy to, as I said, not easy to diagnose, but it is very nice also to inject with ultrasound. Then we have the forefoot, and it's very difficult to examine clinically, especially if there is a lot of fat, like here, or subcutaneous, like here in this patient. You have 1.5 centimeter chest soft tissue, and the joint is here. So this patient doesn't have any synovitis. It's only the fat that accumulates here. And again, dynamic scan, just to lift a little bit these joints to more verify to get better idea of the joint, is there fluid or not. But in this case, at one glance, you see distension of the joint with proliferative changes. And if you put the Doppler on, you can clearly say that, oh, it's arthritis, chronic arthritis is here. So ultrasound offers in the diagnosis of rheumatoid arthritis a lot. I will talk about more in day 3, the whole lesson concerning gout, but here we just notice that there are the 3 elements of gout. The tophus, which is seen here, and these aggregates, white dots, and the most specific for gout is this double contour. We have 2 lines, bony line and the double contour line, which is very specific for gout. Erosions depicted with ultrasound. This is very good method. With ultrasound, it's much more sensitive than X-ray. This is old. We know it for 20 years. For example, in this X-ray, do you see here any erosion? No, there is no, but with ultrasound, this is the very same patient. You can see clear erosion. And it's very often, it comes here lateral and a little bit more on the volar side. So the X-ray beam goes so that it's very difficult to recognize this area. Sometimes you see a small, just like here with normal stony contour, just because the erosion is just a little bit under this to the volar side. Ultrasound offers a nice way to scan the flexor tendons and these intermetatarsal bursae, but also the erosions. And the method is so that you have to go step by step all these 5 areas, bone, and try to find tendon sheet enlargement, bursae, and erosion. In case of tenosynovitis, longitudinal, you find just like in hand, you widening of the tendon sheet with fluid in transverse view. In case of bursa, you find expansion through these metatarsal heads, like here. And in this case, we have a huge intermetatarsal bursa. The patient can feel even that they say that they are going on meatballs. And this is not easy to differentiate from joint synovitis clinically, but ultrasound reveals very rapidly that this is not joint synovitis, it's bursa, it's bursitis. And then the erosions. The same, pay attention to this normal rounded bone head here, but something strange is in the middle. And this was really, this was an early case of rheumatoid arthritis. The young female came to diagnose this, and you see how nice rounded, but there was an erosion in this bone head. It was clear, and depicted like this. So once again, these are normal, and there are erosion in this bone head. Morton's neurinoma, it's difficult to diagnose. As I said, the bursa is in the same area than the Morton, and I think that chronic bursitis can also give symptoms like neurinoma. But neurinomas probably they are more firm. There is not Doppler signals, and there is a typical painful digit phenomenon. But differential diagnosis between bursa and neurinoma, I think it's not easy. But you in some cases you may find lesion resembling Morton. And finally, I try to point the ability to diagnose fractures with ultrasound. It is not uncommon that the patient have started to walk a lot, and they feel pain in their foot, and they think that they have arthritis, but usually the stress fractures come just a little bit proximal to the joint, somewhere here. And with ultrasound, you see the defect in the bone. It's not so discontinuity. There is discontinuity in the bone, and in case of reparative process, there is a Doppler around this lesion. In this case, there's callus formation, thick callus around the bone, and the corresponding X-ray can be seen here. This is already about 5 weeks old stress fracture. So I stop now using again this typical Finnish lakeside image. Thank you.
Thank you, Dr. Juhani. Excellent great conference. Excellent topics, tips on the evaluation ultrasound. Muchas gracias, Dr. Juhani. Gracias, Jesús. Iremos al break de 15 minutos, 10, 15 minutos.
Yeah, we are going to make a break of 15 minutes. Are you agree, Juhani?
Yes.
Yes, okay. Sí, vamos a tomarnos 15 minutos.
Y retornamos.
Okay. Perfecto.
Muchas gracias.
Gracias.
La segunda parte, y con la segunda parte de esta mañana de evaluación con ultrasonido de las enfermedades reumáticas, y habíamos hecho una pequeña variación en nuestro programa. Las dos charlas que vienen con el doctor Juhani son temas específicamente ligados a reumatología. Entonces voy a iniciar con el doctor Jesús Santisteban para que nos haga una introducción de la importancia del ultrasonido en la evaluación de las enfermedades reumáticas, ¿no? El doctor Jesús Santisteban es médico, egresado de la Facultad de Medicina de San Fernando, realizó una residencia de patología en el Hospital Rebagliati de Lima, Perú, por San Marcos. Realizó un fellow en Estados Unidos y después se fue a Finlandia, donde hizo sus estudios de médico internista y reumatólogo por la Universidad de Helsinki. Tiene una amplia experiencia, como 20 años de internista y reumatólogo. Entonces le voy a pedir al doctor Santisteban que haga un resumen introductorio para que después el doctor Juhani vaya directamente al rol de las imágenes. Adelante, Jesús.
En el hemisferio norte las espondiloartropatías son sumamente importantes, ¿no? Porque aquí, digamos, hay una predisposición genética El HLA-B27 es, digamos, un marcador de una clara predisposición genética. Entonces, digamos, la incidencia y la prevalencia de las espondiloartropatías es mucho mayor que en el hemisferio sur. Entonces, para poner un ejemplo, ¿no? Para que ustedes tengan idea, digamos, de la carga genética, acá en Finlandia, hace el año 2007, en una ciudad, Nokia, que es justamente el nombre de la transnacional finlandés de los celulares, se produjo un accidente del desagüe que hizo, o sea, que se rompió y contaminó toda la red de agua. Y como consecuencia de ello, hubo un nivel de contaminación en un país estéril y durante obviamente hubo, digamos, enfermedad diarreica aguda, pero después poco a poco empezaron a aparecer manifestaciones de artritis reactiva y de entesopatía, de dolores musculares, y eso más o menos puede explicar, digamos, cuán importante por la carga genética y por el ambiente estéril es, digamos, las espondiloartropatías acá en el hemisferio norte, ¿no? Entonces, acá hay un fenómeno de envejecimiento de la población y acá y tenemos un sistema de salud eficiente donde hay una amplia cobertura de salud con gran accesibilidad, de tal manera de que, a diferencia del Perú, por ejemplo, la mayoría de los pacientes son, digamos, de mayor edad, y a diferencia del Perú, la mayoría de los pacientes vienen a la consulta con pocos días o con semanas de haber iniciado sus manifestaciones reumatológicas. Entonces ahí el ultrasonido se ha consolidado como una tecnología para el diagnóstico precoz, de fácil accesibilidad y que realmente resuelve en el día a día problemas cuando el paciente tiene al mismo tiempo, o sea, simultáneamente puede tener una osteoartritis y inmediatamente puede tener, y como un hallazgo casual le podemos encontrar una pseudogota o gota. Entonces el ultrasonido es una tecnología, digamos, que se ha consolidado en toda Europa, donde prácticamente caen todos los especialistas, todos los reumatólogos. Yo me formé en la Universidad de Helsinki y desde el primer día como residente yo ya tenía un ecógrafo en mi oficina. Entonces es prácticamente, digamos, un instrumento de trabajo como el estetoscopio para poder, digamos, evaluar sistemáticamente un paciente, ¿no? Obviamente la experiencia de a poco se va consolidando, no es fácil, no somos radiólogos, pero ya con la práctica, digamos, hay un nivel en la que ya tenemos mayor, digamos, confiabilidad, mayor sensibilidad para detectar entesitis, para poder graduar los ecógrafos y para poder, digamos, usar el Doppler de una manera más segura. Entonces, solamente para no extenderme mucho, digamos, las imágenes, sobre todo en aquellos escenarios donde el paciente es oligosintomático, en aquellos escenarios donde el paciente no es crónico, tiene una ventaja muy grande por encima de otro tipo de imágenes o incluso la semiología. Entonces, ahora vamos a empezar, digamos, vamos a darle la palabra a Juhani para que siga con esta charla y él nos va a presentar toda su experiencia, que es fabulosa en cuanto a espondiloartropatía. Muy bien. Juhani.
Gracias, Jesús.
Okay.
Adelante, doctor Juhani.
Thank you very much. So I continue. I put this away like that. Okay. You see this first slide of spondyloarthropathy, evaluation of enthesitis, joint index. Okay. Ultrasound really offers a lot here too, but we start with this picture, cartoon, spondyloarthropathy family. The father or mother is the ankylosing spondylitis, but we have many diseases related to this. I think I didn't understand what Antonio said, but he mentioned reactive arthritis, which is related to ankylosing spondylitis. And in Finland, we have 16% of population HLP27 positive. So we have a lot of these reactive arthritis. And also inflammatory bowel diseases, Crohn's disease, colitis, ulcerosa are related very often to these spondyloarthropathies, and of course psoriatic arthritis. Then there are probably undifferentiated diseases also, but we have this is a very big problem in rheumatology. We have rheumatoid arthritis, then we have this group almost as big as rheumatoid arthritis. So the characteristics are sacroiliitis in this group. Enthesitis is especially characteristic, and dactylitis too. I would like to start with ultrasound of the sacrum or sacroiliac joint. Yesterday we had some minor talk about that, but let's have a look at of that a little bit more closely. We have this dorsal sacral anatomy. There are some important things. Here is, of course, the joints depicted with the blue color, and then we have the sacral crest here and this tiny processus spinosus here. But what is important when you depict with ultrasound are these posterior sacral foramina. There are foramina here. Unfortunately, very often these foramina are obscured by sacral crest. So, for example, in this picture, there is you can't see these first sacral foramina because it's obscured by bone. But this is the schematic picture of sacrum. When we depict sacroiliac joint with ultrasound, the patient is in prone position, and notice that the sacrum is a little bit oblique. There are important landmarks for scanning this, and I think one of the most important is the posterior superior iliac spine. You all can feel it when you touch it, your back. It is the bony prominence you can feel there. Some doctors use as a landmark the fifth spinous processus in the lumbar area, but I use this posterior superior iliac spine as landmark. And then we have these important landmarks, first and second sacral foramina. And this was my landmark posterior iliac, the posterior superior iliac spine. And in ultrasound, we can see this at the closest bony profile, the closest to the skin. I try to find this, and then I go in the direction of the shown here. And now the video runs distally, and I try to find the first and second sacral foramen like this. The first sacral foramen is here, you see, a little bit sacroiliac joint here, and then the second foramen. Let's repeat it. The first foramen, sacroiliac joint, and the second foramen. Why I want to find this? This is because I want to see, I will come on that later. I will be sure if I inject sacral electrons, I want to know where I am. But there are problems of scanning sacral electrons. So the location is deep, the oblique to the probe, and there are very often thick, soft tissues. It is not uncommon that patient might have 5 or even 10 centimeters fat. Of course, there are muscles or ligaments, but the visibility of the joint cleft itself is not easy because it is hidden by the ileum very often. So actually, it can be non-visualized. And then I already said that the foramen can be covered by bone. Anyway, this injection of sacroiliac joint have been studied by Andrea Klauser. He made nice studies with cadavers, but also with patients. And he noticed, she noticed that if you perform the injection at the level of first foramen, the success rate is 70%. At the level of second foramen, 90%. And you have to insert your needle 1.5 centimeters deep to reach the synovial cavity. So you have to go really, really deep. So, but this was only for injecting. I don't personally use ultrasound for depicting sacroiliitis. This is for MRI. There are some studies, but to be honest, I don't believe on these studies. For example, in last EULA Congress, there was a large Chinese study. They tried to evaluate the joint, the resistive index of this area, but we need much more information. Okay, let's go on. That was from the sacroiliac joint. I want to tell you. We come to the enthesopathy title. What is it? It was in the 60s, Gustav Niepel, who introduced this entity to rheumatological literature, but also John Ball, Eric John Bywaters have been related to this enthesopathy phenomenon. What is the concept? The concept is that we have something attaching to bone, ligament, or muscle, and it can be injured by mechanical lesions, metabolic disease, degenerative process, or enthesitis. So this enthesitis is part of the enthesopathy concept, this red thing here. The first ultrasound publication was in the 90s by a Finnish radiologist Lehtinen. They examined spondyloarthropathy, the Achilles tendon. There are clinical indexes examining this enthesitis. There are many, but I just have here the one, which is the most expensive, Mander index. They examine knuckle crest, manubriosternal area, greater tuberosity of humerus lateral and medial epicondyles, iliac crest, and so on, trochanter areas in the knee, and so on. Of course, this insertion of Achilles. These are clinical indexes concerning enthesitis. But we skip this. There are studies comparing ultrasound and clinical endothelial abnormalities, and it is not surprising that ultrasound and depicting is always much more sensitive than clinical, more sensitive and specific than clinical indexes. OMERACT has done a lot of work examining what is enthesopathy and especially enthesitis, and the definition says that enthesopathy is abnormally hypoechoic thickened tendon or ligament at its bony attachment seen in two perpendicular planes that may exhibit Doppler signal, and there might be also enthesophytes, erosions, and irregularity. So this is the ultrasound enthesopathy definition. And then we have another definition for enthesitis. Enthesitis, according to the latest OMERACT definition, is hypoechoic thickened insertion of enthesis close to the bone. What does it mean? It means within 2 millimeters from bony cortex, which exhibits Doppler signal if active, and that may show erosions, enthesophytes, calcifications as a sign of structural damage. In this image, you can see the elementary components. So we have first thickening of the enthesis, and then we see echogenicity changes. It is because of fluid, it's more hypoechoic. We can see enthesophytes, calcifications, and these elementary components can be also found in enthesopathy. But in enthesitis is very specific this, the erosion at the calcaneal level. This is specific for enthesitis, and also that the Doppler signal is very close to the bone, more or less than 2 millimeters. So these two here are the very typical for enthesitis, which is part of the large enthesopathy. And even more, OMERACT, they score these enthesitis as following. Doppler, they give points from 0 to 3. I will tell you more. What does it mean? Hypoechogenicity is off or on. So there is hypoechogenicity. Is it or is it not? And thickened enthesis, no, yes. Calcification, no, yes. Bony erosion, no, yes. So they give points. Doppler signal scoring is graded as 0 if there is no Doppler signal. If there is grade 1, it's 2 punctiform Doppler signals. If there is 2 to 4, it's grade 2 or 1 bigger Doppler signal. Or if there is a lot of Doppler, it is grade 3. So this is the OMERACT scoring system. The latest published on 2019. However, they made a reliability consensus study before this publication, and there were 11 evaluators and 5 patients only, and they said that they used their only binary evaluation, and they evaluated enthesophytes, calcification, erosion, thickened enthesis, and so on. Is there Doppler or not? And you see here intra-observer kappa coefficient, and inter-observer kappa. And how to create this kappa is on the bottom. If there is no agreement, it's less than 0. If there is only slight agreement, 0.2, fair 0.4, moderate 0.6, and so on. As we see, there is relatively poor correlation intra-observer and inter-observer kappa. This is not quite nice. So it is not easy to evaluate these lesions so we should have better reliability. That was on the joint level, but then we have these indexes on the patient level. So we take many different joints and put these together. There are the oldest is Glasgow ultrasound scoring system. Guess at that time they don't have Doppler. We have famous Madrid sonographic enthesitis index, MASEI. We have Italian Grappa, we have Omverac system. So there are competing indexes. In this table, we can compare these different indexes. We see that Achilles enthesitis is evaluated in all plantar fascia, not by Omverac, for a reason or another. Patellar ligament attachment, all distal patellar ligament attachment, only Grappa, surprising. Bilateral quadriceps insertion, all. Triceps, not guess, but MASEI and Grappa, and so on. There are different evaluations. Doppler within 2 millimeters of cortex. MASEI examines that and all others, but not this guess, which was the oldest. And at that time, Doppler was not very common. So, and you can see here what are these. Guess is from Glasgow, MASEI, or Madrid, Grappa. I think it's from more Italian, and Omverac is international. In a very in one study, it was investigated the inter-observer reliability of MASEI validation by multi-center collaborative group of rheumatologists, and it was found that this MASEI score reliability was very high. Interclass coefficient was very high in this Spanish work. Let's have a look more detailed about this. What is enthesis? We have the bone here, and then we have the tendon. Tendon attaches to bone. It is not attached to the bone directly, but there is an enthesial fibrocartilage here between. And then we have the bursal area here. Normally, there are normal vessels can be found with ultrasound. You have to understand this because this is normal. Some feeding vessel. But normally, we cannot visualize pathologic vascularization with power Doppler. As I said, in athletes, if you run 10 kilometers, according to Torp Pedersen's group from Denmark, they can find Doppler vascularization around healthy Achilles tendon if you make a mechanical stress. Simple Iden examined and validated the endothelial fibrocartilage in ultrasound. She examined especially this connection from tendon to bone. This is very interesting that there is this fibrocartilage here. The tendon is not attached to on the bone, but it grows into the bone. So the tendon cells, they change gradually to bone, and vice versa. Bony cells, when you move to the fibrocartilage, they change to tendon cells. So this makes very strong connection from tendon to bone, just like in trees. When this fork grows into the tree, this is very hard combination. You hardly can cut this. The fork can be cut somewhere else, but not usually at this point. It's very hard. It's the same genius hard connection. So, and I say about this anisotropy. If the ultrasound beam is not quite perpendicular to the target, you can't see it. You have to change a little bit the tilt the probe to see and to prevent the anisotropy. Anisotropy is always when you have something oblique target. And erosion, where do this erosion form? As we already have seen in some photos, they are formed at the bursal part of fibrocartilage. Here, this is typical site of erosions. And now we see here a typical inflammatory enthesitis erosion and Doppler signal. And in case of mechanical or degenerative tendinitis or enthesopathy, it resembles like this. Well, this is in pictures, and in real life, it's not always so easy. There can be also in patients with spondyloarthritis, they can be something like this. What is enthesitis? How does it differ from enthesopathy? Because this Doppler signal are at the cortical insertion, as I said, 2 millimeters. Doppler signal can be present even in absence of cortical irregularities. Okay. So here we have a huge, we already saw this in last ankle lesson lecture, huge erosion, bursa, and thickened Achilles tendon. This is a typical enthesitis. And it is very valuable when you have, for example, for the first time, the patient. You can say that the patient belongs to the group of spondyloarthropathy. Again, normal enthesis of Achilles tendon. And now, extended view. Actually, we already have seen these two. This is a typical, more mechanical and degenerative Achilles tendinitis. The tendon is inflamed, not at the enthesis site, it's more proximal. And again, Achilles tendinitis, not insertion, more proximal. Again, Achilles tendinitis and retrocalcaneal bursitis. As I said, this can be, I'm talking in practical life, this can be found also in patients with spondyloarthropathy, but theoretically, we think that this is more mechanical or so on, a degenerative lesion. And then Achilles tendon calcifications can be found in the tendon. These are post-inflammatory changes, chronic changes in the tendon. Where are these enthesophytes? Where can we find them? Outwards, midline, inner, or outside? Usually they are more on the surface of the tendon. Typical enthesophytes. Plantar aponeurosis is one site of typical enthesitis. We already saw this normal 3.5, and in case of fasciitis, thickening and echogenicity goes more down to hypoechoic. And this peroneus brevis enthesitis, which is not, they don't read this for in these indexes, but I highlight that you can find actually enthesitis in all over the body where is the connection of tendon to bone, but these indexes, they don't recognize these. I wonder why. And for example, tibial anterior enthesitis. But this is a real enthesitis in a patient with spondyloarthritis. But it is not, I don't know how they handle this in their studies when they found this other, because this is important in practical life. And then quadriceps enthesis, attachment of quadriceps to the patellar pole. We already actually saw this also, thickening of the tendon quadriceps to the patellar pole. But repetitio e mater studiorum, it is always nice to have something new. And infrapatellar enthesitis, this wonderful anatomic corresponding image and ultrasound image. Professor Peter Palin from Hungary have made this more than 20 years ago, these wonderful corresponding anatomical images. And this normal enthesis and this huge patellar enthesitis with erosion. And chronic patellar versus acute patellar. This is acute patellar enthesitis, thickened enthesis with Doppler signal, with swelling of the tendon, and on the other side, chronic case with the enthesophyte. And the tibial tuberosity enthesitis, the distal end of the patellar tendon, the distal end here. There is also a bursitis, chronic bursitis, deep infrapatellar bursitis. Enthesitis, attachment of the patellar tendon to fibula, tibia, sorry. And the lateral hip, we already discussed that yesterday, but let's repeat it. We have on the lateral hip, we have gluteus minimus, attaching and the anterior facet. We have gluteus medius in the lateral superior facet, and gluteus maximus is on the top, but it is not attached to the trochanter area. Chronic enthesitis at the level of trochanter gluteus medius, thickened tendon with bony irregularities with Doppler signal. And epicondylitis at the level of humerus, tennis elbow, thickened tendon with Doppler signal. And again, pay attention, ultrasound can reveal that it is not quite tendinitis, it is a ruptured tendon, and the symptoms are quite the same than in tennis elbow, painful lateral epicondyle. And medial epicondyle too can be inflamed. Actually, we saw this also yesterday. And triceps area, grayscale and with Doppler signal. Thickened enthesis with hypoechoic texture with, and if you put the Doppler on, you see Doppler signals as a sign of inflammation. So there was a publication by Anna Maria D'Agostino, who is a famous researcher of this area, a professor in France, Paris. Can you depict, does Doppler has diagnostic value? She examined for 2 years 180 patients with symptoms suggestive for spondyloarthritis, and she examined with ultrasound lower limb and elbow, and she noted that at least one enthesis, power Doppler positive, showed good predictive value for diagnosing spondyloarthritis in future. Then we might ask, when we find these enthesitis, can we treat them? Yes, we can with our modern medicine, especially biologic treatments. There is responsiveness. For example, in this Esperanza Naredo study, they found that power Doppler score here in red box, it diminished from baseline to 6 months, and it was statistically remarkable decrease. And very late study by Collada, published in Scandinavian Journal of Rheumatology, they examined Doppler enthesitis. It showed sensitivity to change after biological treatment in patients with spondyloarthritis and psoriatic arthritis. They had 24 patients, and these got biologic DMARD for 6 months. They used clinical scores and Massey Omeract index scores, and these both improved at 3 and 6 months. So it is nowadays possible to treat these enthesitis. There are also publications between ultrasound and MRI, and it has been shown that ultrasound is even more sensitive than MRI in depicting these lesions, and ultrasound correlates better with clinical findings than MRI. MRI is in this Sibel Eiden's work, it was a little bit it was not so good. How about whole body MRI? we have the latest technology is to scan the whole body, and this is very dangerous method, because if you make whole body scanning, it is possible to have 70% findings in healthy patients. So it is very I don't know if you, but it really offers, for example, in cases of enthesitis, it could offer something extra. But these are very expensive machines. I don't know, is it there in Finland? Not yet. I think, no. As far as I know, even in Finland, we don't have this whole body MRIs. Okay, but that's probably future. And here is my dear wife making snow work. Last springtime, we have had a lot of snow. As you see, she has to make the track to get into the house. So actually, this was after I put the snow out of the roof, but she had to work also. So this was end of this session. Thank you.
Thank you very much, Dr. Johanny. Continuamos con la siguiente conferencia, Jesús, por favor.
Yes, we are going to continue the next, or would you like a small break? It doesn't matter.
No,
okay,
we can go on.
Okay, continuamos. Continuamos con la siguiente.
Gracias.
Okay, I changed the.
Okay, we are going to change the.
Yeah,
file.
We changed the file.
Okay, we are going to the question and answer. We are going to send to the later part of the lecture.
Wait here. Here we go. Here we go. And okay, recording over. So, and now we make this trick to get this. Okay.
Okay, very good.
Okay. Now this is in black and white, so I think the visualization might be quite good. So the last third talk today is ultrasound of systemic chronic diseases, evaluation of vascular, pulmonary, skin, muscle. Okay, a lot of different point of views. So we start from depicting vasculitis. I'm not talking about atherosclerosis or vein thrombosis, because this is a more or less, I think, rheumatological meeting. So I'm talking about large vessel vasculitis now. And we have this the most common large vessel vasculitis is temporal arteritis, also called cranial giant cell arteritis, or temporal arteritis. Very often the people, always the people are more than 50 years. Usually they are elderly, more 60, 70 or something like that. But they have very often findings also in the axillary area, sometimes even in carotis area or subclavian, but in axillary too. There is also a so-called idiopathic aortitis, but large vessel vasculitis under 50 years old, we call them Takayasu arteritis. So the most common vasculitis are temporal arteritis, and in people under 50 years, Takayasu. I'm talking about this. There are several imaging modalities for large vessel vasculitis. Doppler, NIAS Doppler sonography. Then we can have angiography, digital subtraction angiography, computed tomography, and with angiography, magnetic resonance imaging with angiography. And then we have this PET imaging plus CT. So we have different modalities for depicting of, but we are now talking about ultrasound. According to EULAR recommendation, early imaging should be performed in suspicion of giant cell arteritis, and always to compare with clinical presentation. And imaging should not be delayed because of blindness. The people can get blind if you miss temporal arteritis. So in some countries, for example, in Germany, Berlin, or also there are emergency tracts for this kind of people. So they try to get these people to contact under 24 hours. If you start glucocorticoid before imaging in 4 days, the sensitivity of ultrasound is decreasing. This is also the concern of other imaging modalities, MRI, but also PET imaging. So it would be nice always to scan and examine fresh cases, and not. But of course, you have to start with in some cases before imaging, because the most important thing is to try to prevent blindness, which is the bad sequence of temporal arteritis. Here is the father of color Doppler ultrasound in temporal arteritis, Professor Dr. Wolfgang Schmidt from Germany. However, there was some publication in the 70s and 80s by Kelly, but Dr. Schmidt was the person who made famous this color Doppler imaging in Lancet 1995 and in name 2. And he showed that the color Doppler depicts the lumen and thickening of the walls of the temporal arteries. In this middle panel images, you see normal case. There is the lumen and the wall, the mural area in long axis here. And in case of temporal arteritis, you see something different. You see, according to Omeract, you see hypoechoic wall thickening, well delineated toward the luminal side, visible in 2 perpendicular planes, transverse and in long axis. So this is typical what we see in temporal arteritis. We call it halo sign, or donuts, or halo. Okay. According to EULAR recommendation, if you suspect this kind of disease, temporal arteritis, or also called cranial giant cell arteritis, the first choice is ultrasound of temporal and axillary arteries. And then we have also called non-compressible halo sign. So here we have the halo, the same definition we saw in the last page. Halo. And if you compress with your transducer, you still see the halo. You still see the halo. According to Omerac definition, thickened arterial wall remains visible under compression. The echogeneity contrasts hypoechogenic because of vasculitic wall thickening in comparison to mid-hyperechoic surrounding tissue. So you compress it, but you still have. I have a nice video next. What happens in normal cases? See here, I'm compressing. It totally disappears. So this is normal. When you compress it, you don't see any halo here. So there, because there is no edema. This is normal. How do you perform this? When I do it, I'm sitting in front of the patient. Patient is in supine position, and then the machine is here on the left. I'm operating it with my left hand. And I first scan the main artery, and then we have the frontal branch and the parietal branch. So we start with the, I go now the main branch and the frontal branch, then I come back, and then I scan the parietal branch, like that, like that. We need high quality color Doppler equipment. It should be more than 15 megahertz. Nowadays, it is possible to buy, if you have a lot of money, even 50 megahertz transducer, but that's expensive. And but at least 18, 20 is good megahertz. And try to keep the same conditions, the patient position, room light, and the same machine and the same settings, so that you can, it is very difficult to if your machine is changed and you have PC emergency rooms, and so it's not nice. The changes are very little, a few millimeter changes. So it is very important to have the same conditions all the time. Color Doppler or power Doppler. I use power Doppler, but if you use color Doppler, you should raise your repetition frequency until 2000. Okay, and now the color signal should be cover the lumen. You have to adjust the color button so that it adjusts just in the lumen, not over. Wolfgang Schmidt says that you have to scan 30 healthy old persons to get familiar what is normal, so that your eyes can learn, and then. But you always, if it's suspicion of patient and temporal arteritis, you can also scan other areas than temporal areas. For example, if the patient says he has occipital pain, you have to scan the occipital arteries or head arteries, facial arteries, and so on. Just put your transducer, try to find is there other areas that are involved. And then axillary artery. I'm sitting in the same position than in last slide, but now I'm examining axillary. The patient is turning his head, his upper limb like this. Okay, this is the way how to scan. You can, of course, scan your carotid areas or even try to scan the subclavian areas, but that's not easy, as you know, with ultrasound. Then, again, Euler recommendation. If you have a strong clinical suspicion and the imaging is positive, no further test is required. And vice versa. If the clinical probability is very low, for example, losing a vision without headache, sudden blindness without a headache, and the sedimentation is very low and imaging is negative, this is very probable that it's thromboembolic complication more than it's not temporal arteritis. In temporal arteritis, we usually have always sedimentation rate and CRP are raised, and the patient have, for example, fever or they feel not well, and they have this headache and so on. You have findings, clinical findings. So expert reliability in examining ultrasound is very high, and video reliability of sonographers is as good as pathologists when they examine their slides for the histological slides. So ultrasound is quite a nice study. Here even more, how good is color Doppler ultrasound? It is as good as MRI. And if you have the halo sign, the sensitivity is 75, specificity 83 compared to histology. But this is a little bit old meta-analysis. Halo sign is infrequently found in kinds of arteritis with periadventitial small vessel vasculitis. So if we have this small vasa vasorum vasculitis, it's a difficult to diagnose. But if you find on both sides halo sign, it's very specific for temporal arteritis. And as I said, it is nice to examine also these axillar areas and other areas. You can find more widespread arterial lesions elsewhere. Vertebral arteries are not very common to get involved in large vessel vasculitis. According to Wolfgang Schmidt, color Doppler sonography findings do not predict ocular complications. However, so there are good and bad points of ultrasound in diagnosis of temporal artery. Good point is that you can perform it quite easily at your office with low costs, high resolution. There is no radiation, and you can repeat it. You can during follow-up, if necessary, you can repeat it. But it is operator dependent. As I said, you have to be familiar with the machine and the technique, and you have to know what is normal, what is not normal. And the limitation, of course, is that we can't see the thoracic area very well. But then I'm moving to Takayasu. It is you can use ultrasound in screening and follow-up of Takayasu, but especially in depicting carotid area, but vertebral area is limited, and the subclavian arteries are limited in the thorax area. Typical, you can find long, homogeneous, concentric thickening of the wall. Okay, and I have here some own cases. In 2005, I had 30-year-old lady with 100 millimeters per hour ESR. You see here in long axis how thick are the carotid communes here. And these middle panel images are my own images at that time. You see there is very thin intima media area compared to this young lady. And now this young lady had got treatment And in 2015, it was much thinner intima media area compared to this. So at one point, it is when you treat it early enough, it is possible to reduce this the enlargement of the wall thickening. As we know, we have also the stenotic phase. If you don't treat it, and if you don't treat it well, it can be even get obscured. Okay. So as a summary, imaging of large vessel vasculitis, ultrasound, color Doppler ultrasound is very available. We cannot depict thorax. It's fast, high resolution. We can depict the walls and lumen. That's important, walls and lumen. Using angiography, it's not very fast, and this is important. You cannot with angiography depict the walls, the mural changes, and this is very important to see is the other walls thickened. CT angiography, this is very nice for large vessels, not for temporal arteritis, but other vessels in the body. MRI especially, availability is not so good and it's not so fast. The resolution is not the best, but you can image the luminal changes and mural changes. And we had PET CT, which the availability is not in every hospital, but it's not fast. And it is not very good in luminal changes, but we use it for detecting mural changes. We try to find inflammation in the walls. So this was the I think the end. Yes, the end of session 1, vascular. What I wanted to tell you about the vascular imaging sonography. And then we change for the next topic. We just relatively quick have a look at the ultrasound in the thorax lung area. What we can depict are bony fractures in a costal area. Of course, everyday life is pleural fluid detection, and in some extent, interstitial lung diseases can be found also, but probably we use high resolution CT for that. Maria Hekeler, Stefan showed in early 90s how normal rib looks like, and when there is a rib fracture, you can in a nice way depict that. This is not quite acute. You see there is some callus formation already found here, but anyway, you can use ultrasound to detect bone fractures in the thorax area in a nice way. Pleural fluid, this is not uncommon everyday life. X-ray, sometimes we might have difficulties to say, is there fluid or is it already round pleural area, but with ultrasound, you can detect quite easily the fluid, excess fluid in the thorax cavity. And then ultrasound and interstitial lung disease. We can see first the pleural line, which is normal here. And then when there is irregularity and thickening, we can pay attention to the pleural line in this panel C even more. And then next are these so-called P lines or comet tail artifact. Normally, this lung tissue does not produce lines, but if the septa are thickened, we can see typical beams, and we call it comet tail artifact. And this has some correlation to the interstitial lung disease. This is I don't have this kind of patients many, but here is some video to produce you. You see here a little bit thickened pleural line, and there is some comet tail producing into the pulmonary tissue. So, but as I said, of course, usually we use high resolution CTs in examining patients with suspected interstitial lung disease. But there has been a lot of studies also in the area of this lung. Then we move to skin. And in dermatology, of course, dermatologists might evaluate tumors and some sort of inflammations, but I'm not talking about that. In rheumatology, we try to evaluate the thickness of skin in systemic sclerosis. That's our indication. And again, we need a high frequency transducer for at least more than 15 megahertz. It is nice to have as high frequency transducer as possible, but as I said, these are not common. These are very expensive. What we see with the ultrasound, we see the membrane of the probe, entry echo, epidermis, and dermis itself. And they have measured here, it's a 1.41 millimeter in normal person. And then we have the hypodermis here, fascia. But normal skin is about less than 2 millimeters, let's say, 2. And in case of systemic sclerosis, it is thickened. As you see, these two images are not equal. The magnification is in here is much bigger, so it seems that it's as thick as this, but I have measured here 4.8. This is 4.8, so it's double. It is one of my patients. It's a double that measurement than in normal. And pay attention, there is also hyperechoic areas in the hypodermis here. So changes also in hypodermis. It has been examined, this ultrasound and skin, and it has been found that ultrasound is very reliable to examine the thickness of skin, as we see here, corresponding very well with the histological measurement, high correlation. Yesterday, it was, we talked about elastography, and I was not very enthusiastic with arthritis elastography, but you might try it in scleroderma. Elastography examines stiffness of tissue, and in scleroderma it might work. For example, in this case, This is the grayscale of one patient. It is on the thigh area, 53 millimeters thick skin. And in elastography, it shows we produce energy, and elastography examines stiffness of the tissue. So it is coded as color. This is stiff, and this is soft. So red, yellow, and green is soft, and the blue color is stiff. In this case, so but according to recent publication, it has been shown that elastography has a potential role in skin evaluation, but further research is needed on early disease diagnosis, disease monitoring, and evaluation. So it is not ready yet for, and actually we have known elastography for more than 10 years, but it has never developed in rheumatology, a big topic, even in skin evaluating the skin. Of course, we can see calcifications easily with ultrasound. In hand area, there is a tendon here, and under the skin, between skin and tendon, there is calcification. In this case, of course, X-ray evaluates in a very nice way the amount of how much there is this calcification. Vascularity, we can examine the vascularity of hands and digital arteries very well with ultrasound. Normally, you can see pulsating arteries in warm hand until the very end of the digit, but in case of scleroderma, the arteries are narrow, and they can even stop. The flow can be seen that there is no flow distally. So this is of course possible to use also in evaluating vascularity. And finally, we have the last topic is ultrasound and muscle. Of course, it is possible to examine tumor-like conditions, like one of the most lipomas and so on, cysts and ganglions, but I'm not talking about that now. And some local infections we can find. Ultrasound can be used in traumatology for detecting ruptures, hematomas, and evaluating volume changes. Is there atrophy, or is the muscle for a reason or another thick? And then we can try to find changes in muscle ecotexture in different neuromuscular and inflammatory diseases. This is a difficult topic. I will discuss about this. But if we think about inflammatory muscle diseases, MRI is probably more sensitive and better. Because there are so many difficult things in I will show you. But ultrasound can be formed can be performed muscle biopsies as well. This is, I will end my talk with that. So yesterday I already showed that all kinds of strange intramuscular phenomenon you may try ultrasound, and in this case with high CRP I found in deltoid muscle this lesion which was enhanced with Doppler and in long axis, and if you put a needle into the lesion I got BUS, Staphylococcus aureus BUS. So in case of intramuscular abscessus, and we already saw this when I talked about earlier this evening or tomorrow or morning in your country about the Achilles tendon partial rupture or total rupture. You already saw that image. Yesterday we talked about hip joint. It is possible to evaluate in the anterior hip the adductors. Very nice memory aid is Alabama. You remember these adductors when you remember Alabama. This is I learned it from Tony Buffar, who is a great sonographer from Michigan or from United States anyway. So this Alabama comes from words adductor longus, A and L. Then we have A and B, adductor brevis, and then adductor magnus. Because you never learn what comes first, what comes then. But if you learn Alabama, is adductor longus, brevis, magnus. So these are the three adductors. And then we in transfer image we have also gracilis here, but not in long axis. So in this case, we have a ruptured adductor muscle here, and the cavity is filled with fluid hematoma probably. So in traumatology, radiologists use this method, of course, in athletes and so on. But I skip that. Well, this is one of my old elderly patient who came. He had hematoma in forearm. She had large brachioradialis rupture and hematoma found in muscle tissue. And yesterday I already talked about the measuring tight muscle and other muscles too. For example, here I have OA patient who has much thinner muscles. He has pain and he has not used his leg and limb as much as the healthy side, which has a much thicker muscles here. So this is just to encourage the patient to practice more, because if the muscles are weak, he's unable to do his daily activities. So for gymnastics and physiotherapists, it's nice to send this patient to get the muscles thicker. Then we have a very difficult subject, is the epitexture changes. Normal transverse image of muscle. We call it starry night. Starry night. It's I don't know, is this starry night, but it is called the transverse image. And here we have some dystrophy patients that has ground glass phenomenon. Well, actually, it is very different than the starry night normal image. Then we have here changes in the upper layers of the muscles, making attenuation to the bottom of the image. Then you might have focal areas of hyperechogenicity here, or so-called see-through lesion in inflammatory. This is, I have never seen this kind of lesion. Then you have subcutaneous lesions in inflammatory, probably in dermatomyositis, or probably in scleroderm too. You could have a subcutaneous layer thickness. But anyway, in chronic inflammatory myositis, there is the volume change to atrophy and the echogenicity goes up. So it's a hyperechoic because there is fatty degeneration here. Calcifications we can see, if in case of fasciitis, probably the fascia can be thickened. There can be in inflammatory area, the deep flexor can be hyperechogenic in inflammatory muscle disease. And these two images were from a young patient with neurological nerve problem in some area. So in the affected area, there is hyperechogenicity because of fatty transformation compared to this more normal side. And even this kind of month-eaten lesion, I don't know. I have not seen that. But we have problems with muscle ultrasound. Why? For example, the device can be device A. It's totally different image than device B. So the devices can be different. And then if you just make a perpendicular image or tilt the image, they change. So scanning technique can be different. And then in very small child might have different kind of muscle tissue than adult. And when the age get older, you have more or less atrophy and fatty tissue in the tissue. So what is normal? It is difficult to say what is normal. And then if you have very thin patient, you can see nice muscle tissue, but then if you have very thick obese person, the thickness of fat has influence to what you see under there is probably also fatty degeneration because of the fatness. And of course the image quality. In older images, older machines, you don't get so nice image than in nowadays. We have very nice high resolution images. So anyway, the conclusion here is that qualitative ultrasound is very dependent on observer experience. So, and machines, etc. So I think that muscle ultrasound is good if it does not, we have not seen the whole picture. But it's good. Muscle ultrasound might be good if you have a lot of patients, you have a steady conditions, you have the same machine, and you have to learn to scan these patients. So this is quite a difficult area to make diagnosis just using ultrasound of the muscle. But where you can use ultrasound is to guide biopsies. For example, in this case, we had gastrocnemius myositis in MRI. So with ultrasound, it's easy to find this gastrocnemius muscle and to perform, to put the needle exactly into that muscle and take the biopsy. How to take the biopsy? What I use these TrueCut needles. 14G needle is needed. You can take thigh muscles, usually vastus lateralis, leg, tibialis anterior, or upper arm, deltoid muscle biopsies. And it is very important that the cutting edge is transverse to the muscle. So this is the Starry Night image, transverse, and so that the needle can cut against the fibers. So not in the right direction of the fibers, but transverse to the, so that it really can cut pieces. And you can take, if you have only elevated creatine kinase levels, or based on the information by MRI, as I showed in the last slide, or EMG. But anyway, ultrasound is, I think, valuable in taking samples from the muscle. So this nice image, I like to stop now, and you can we can have a talk and conversation.
Yes, we are going to discuss. We are going to start the discussion, also the question and answer. If you have some questions, don't hesitate to ask before. Ok, bueno, yo creo que pasamos entonces a la sesión de preguntas, respuestas. A ver, César.
Thank you very much, Dr. Johanny. Great, your conference. Excelente imagine, points. Excelente.
Thank you very much.
Thank you very much. Excelente. El doctor Calvo ha levantado la mano. Por favor, Omar, dale el micro al doctor Calvo. Dígame, don Armando.
Okay. Thank you so much, Professor, for your teaching. It's very important for us because we are a group of rheumatologists in the audience.
Yes.
I want to speak in Spanish because it's so easy.
Okay.
Lo que hoy día nos ha presentado para los reumatólogos es muy importante porque nos está mostrando que ya no es posible la existencia de un reumatólogo sin ecógrafo. O sea, realmente hemos visto cómo a lo largo del tiempo la ecografía se ha hecho un elemento importante para el ginecólogo, para el endocrinólogo, para el urólogo, y para el reumatólogo cada vez es mucho más importante. La única dificultad ha estado en el precio de los equipos, pero los equipos cada vez están siendo más asequibles, incluso están apareciendo equipos que uno los puede utilizar con su smartphone y son relativamente económicos. Pero ya no podemos dejar la ecografía, el ultrasonido lejos del profesional reumatólogo porque simplemente es una extensión de nuestros sentidos. O sea, se tiene que entender, como mencionó el doctor temprano, es como el estetoscopio. Sí, yo diría es más que eso, es una extensión de nuestros sentidos. Realmente puede detectar signología mucho más precoz que al examen clínico. Y eso es lo que hemos visto, por ejemplo, en las espondiloartritis. Y eso es lo que está mostrando en su segunda, en la exposición en la cual ha mencionado el uso de múltiples entidades, a la cual pudiésemos añadir Sjögren también, porque podemos ver las glándulas parótidas.
Claro.
Pero eso no significa que haya una intromisión, un intrusismo con el trabajo del radiólogo, el imagenólogo, porque como ustedes también han podido apreciar de las presentaciones, es sumamente complejo, compleja la evaluación musculoesquelética sistemática y, y, y profunda. Pero en manos del clínico es útil porque ya es una exploración dirigida a lo que va a buscar. Por ejemplo, nosotros podemos buscar la entesopatía y la vamos a ver más fácilmente. Y hoy día hemos visto algo que la otra vez estuvimos haciendo una ecografía para entesopatía y decíamos, no encontramos el Power Doppler positivo, pero hemos visto que el Power Doppler positivo fuerte no es necesario para el diagnóstico, incluso a veces puede estar ausente si las lesiones son crónicas. Entonces, ahí
Tratamiento.
una utilidad del ultrasonido en esas áreas. Igual, hoy en día el diagnóstico de la arteritis temporal es sumamente precoz. Eso que les parece raro de 0 a 4 días es una realidad. Ya en el hospital hemos podido hacer diagnósticos muy precoces y siempre trabajando de la mano con el doctor César Ramírez, que él nos ha apoyado permanentemente para que podamos tener un acceso precoz a las ecografías. Ahora,
Doctor, perdón,
sí.
un minutito, Carlos, quiero hacer la traducción respectiva porque
Perfecto, perfecto.
van a haber muchas ideas. Do you like in English or in Finnish? Which one would you like?
It's up to you.
Okay. The Dr. Calvo is the chairman of the Department of Rheumatology. He said this is important, this new technology. He's very grateful about the extension, the useful of the ecography in order to make assessment in very general way. I think in Peru, the most important factor that make difficult is the cost of the equipment. But anytime, through the time, the cost of the ecographies are cheaper and cheaper and makes the accessibility and the penetration of the ecography easier. And he wondered about the useful and the how important tool for assessment in the day-to-day base for not only for the rheumatology is in order to detect the early findings in thesis and in this kind of thing. And he said that there is no at all intromission, there is no overlapping with the rheumatologists and the radiologists. There is a complementary between two disciplines in order to make a reliable assessment. Ok, doctor Calvo.
Sí, de acuerdo. Ahora, en relación a las espondiloartropatías, nosotros en Perú y en Latinoamérica en general tenemos espondiloartropatías, sobre todo del tipo reactivas y las indiferenciadas en mayor número. De ahí sigue la artropatía psoriática y no es tan frecuente ni la espondilitis anquilosante ni la asociada enfermedad inflamatoria intestinal. Y queremos explicar eso probablemente porque la prevalencia del HLA-B27 en nuestro medio está disminuida. Ahora, de las espondiloartropatías, cuando hemos nosotros explorado su etiología, también es diferente a la que se reporta en los países nórdicos, ¿no? Los países nórdicos como Finlandia, Noruega, siempre están reportando sobre todo las asociadas a enfermedades sexuales, de transmisión sexual, pero ahora me sorprendo porque han encontrado también cuadros en relación a esas infecciones que ha ocurrido recientemente. En cambio, en nuestro medio, donde pensábamos que debíamos encontrar asociadas a infecciones intestinales y siempre hemos creído que así ha sido, la verdad nos llama la atención porque cuando se hizo un estudio con el doctor Espinosa, al cual le enviamos muestras de diferentes países latinoamericanos, nosotros encontramos que la verdad había más bien asociados a artritis reactivas una serie de gérmenes más bien infrecuentes, ¿no? Si bien es cierto, se veía salmonela, pero se veía también micoplasma, se veían pseudomonas y entonces Neisseria meningitis. Entonces, es interesante quizá la prevalencia de diversas infecciones hace que nosotros en pacientes predispuestos genéticamente podamos ver esos cuadros reactivos asociados a gérmenes no reportados frecuentemente, ¿no? Y, esa es y eso es lo que yo quería decirle al doctor en relación a Perú y las espondiloartritis.
Puhutaan nyt Suomea paremmin. Joo. Kyllä siellä Perussa se on tämä eniten. Se on ensisijaisesti, jos puhutaan espondylotropatia, se on ensimmäinen tämä on indiferentiaati, se on tämä maritamatomba, joku toinen on, se on tämä reaktiivinen, tämä on psoriaasi. Eli se on, ei ole niin paljon kroonitauti, eli ulceratiivinen koliitti. Ihan ajatellen, että voi olla, että liittyy varsinkin, koska HLV-27 se on väestössä ei ole niin korkea kuin tämä Pohjoismaissa. No? Ja sitten, että hän ajatteli, että viime aikoina siellä on löytänyt, että on paljon eri etiologiaa, esimerkiksi salmonella, mycoplasma, pseudomonas, Neisseria meningitis, eli se on eri bakteereita, joka ei ole raportoitu tavallisesti.
Okay. Interesting. Yes.
Puede continuar, doctor Calvo.
Bueno, ya básicamente hemos abarcado los dos aspectos que queríamos tocar. Uno, acá en Cayetano, hacer público nuestro agradecimiento al doctor Ramírez que nos permite un acceso rápido al estudio ultrasonográfico en diferentes casos, también en otros, en el área radiológica y etcétera, pero ahí se hace muy importante porque no solamente tiene que permitirnos el acceso al equipo, sino también él tiene que estar presente porque tiene que ser un ecografista pues muy entrenado para poder dar realmente una información valedera. Pero entonces a todo este auditorio yo los exhorto a que piensen en incorporar el ultrasonido a sus prácticas en músculo esquelético, es fundamental. Gracias.
Hän kerroi, että hän kannustaa kaikki reumatologit käyttää se on tämä ultraääni, ja koska hän on reumatologi, mutta aina pitäisi kutsua tämä tohtori Ramirez, joka on radiologi. Se on ihan molemmat tekee tämä arviointi. No se on nyt hän kannustaa, se on sama kuin Euroopassa, se on kaikki reumatologit pitäisi käyttää tämä ultraääni. Muy bien.
Muy bien, tenemos otra pregunta. Gracias, doctor Calvo. Tenemos a la doctora Karina Villacrés. La doctora Karina Villacrés es radióloga, ¿no? Se formó con el doctor Resnick en Estados Unidos y muchos años ha dedicado su trabajo a la radiología musculoesquelética, básicamente resonancia. Ahora trabaja en la clínica angloamericana. Karina, puedes hacer tu pregunta si deseas, por favor. ¿Cómo estás? Buenos días.
Hello, good morning. Thank you for the lectures. It was very, very, very nice to find people interested in musculoskeletal ultrasound. And my question is just is puntual, how I could differentiate an entesophite of calcification by ultrasound, because it's a confused concept for me.
Yes, thank you for the question. I think, well, it is not, I think, not so important to differentiate, but the both are actually the same calcifications. Probably enterophyte is more at the superficial side of the tendon, and in appearance is more long, and the calcifications are more like stones in the tissue. So, but I agree, it is. I use the both enterophytes and calcifications in my when I describe some lesion. I think it's not the most important to say that this is what and this is what. So that this is my opinion. Thank you.
Muy bien. ¿Alguna otra pregunta, por favor? Si desean, lo escriben al chat y con todo gusto con el doctor Santisteban vamos traduciendo. En realidad, esta mañana ha sido una mañana espectacular, ¿no? Después de tobillo y pie, pasamos a unos temas sumamente importantes. Y en la literatura norteamericana, que es la que básicamente nos nutrimos, quiero que le preguntes, por favor, Jesús, nosotros utilizamos el concepto de tendinosis, ¿no? Tendinosis y versus tendinitis, ¿no? Nos remarcan siempre que debemos hacer nuestros informes con tendinosis, ¿no? Que es una alteración de la estructura del tendón, mientras que tendinitis es un signo clínico. ¿Qué conceptos le ameritan al doctor Giuhani, por favor?
Io sono io si parla io marcano tendinosi versus tendiniti, no? Se la perusa sono cose tan maltendinosi.
Yeah, I think tendinosis is something much more wider expression than tendinitis is when you see something is clearly inflamed, it is thickened, hypoechoic, and with Doppler signal. And tendinosis is actually there is as far as I know not very exact definitions of that. We think that tendinosis is probably something related to degenerative microfractures and so so I would use tendinitis when there is clearly signs of inflammation, and tendinosis is something which is not quite straight inflammation, but you're right, it is not easy to say the definition of what is what always. We have a discrepancy using these phrases. Thank you.
Sí, o sea, bueno, la tendinitis es cuando hay una clara evidencia de que hay una inflamación del tendón, y la tendinosis es como un cajón desastre, ¿no? Donde están el resto, ¿no? Las enfermedades degenerativas, los microtraumas, etcétera, etcétera. Y no es fácil la diferenciación.
Ahora, en la evaluación del pie, por ejemplo, buscar neurinoma de Morton no es fácil. Hay una maniobra que utilizamos, la digitopresión. Él utiliza la digitopresión para buscar Morton.
Morton neurinoma, se la per usarla cauta mala se la sorme la
okay,
kosketu sarkuta joku kosketu sarkuta oletko sinä kautta nyt sellaisia menetelmä?
Well, the technique is that we use longitudinal scanning with high frequency probe between the bones using dorsal scanning, and then you can push with your thumb on the volar side, and there is also the technique that yes, you can squeeze, compress with your fingers from fifth between first and fifth metatarsal head, and try to squeeze these and try to make something coming out of from the midtarsal areas. Yes, there are techniques, but different techniques for trying to depict this neuronormal lesion.
Sí, o sea, él utiliza uno en la cual en la cara, digamos, plantar, digamos, usa el pulgar, pero también usa, digamos, o sea, digamos, aprieta, digamos, el dorso, o sea, los dedos del pie, ¿no? O sea, para poder, digamos, generar mayor sensibilidad, sí.
Y si duele hay que buscar, ¿no? Si duele hay que buscar. El tema de las entesopatías en realidad ha sido una charla fabulosa, ¿no?
Son de
generalmente buscábamos a nivel del tendón de Aquiles, ¿no? Y bueno, el espectro es amplio, ¿no? Entonces, lo dijo el doctor Calvo, no necesariamente para la definición tiene que haber Doppler power positivo, ¿no? Y es dentro de los 2 milímetros de la inserción del tendón. Quisiera que amplíe eso, por favor.
O sea, que la yempi taman con 4 centímetros tama, solamente si insertion pseudusa.
It was 2 millimeters. So yes,
2 millimeters.
According to these researchers, Maria D'Agostino from Paris, he has an Omeract group. They stress that it should be the Doppler should be very close to the bone, and that is typical for enthesitis. And in enthesopathy, it's more than 2 millimeters. It's somewhere else, this Doppler.
Sí, o sea, 2 milímetros, digamos, de la inserción.
Claro, ese es el concepto, ¿no? Según Nomera.
Sí.
Ahora, hay otro detalle importante, la evaluación de la articulación sacroiliaca. Obviamente utiliza transductores de baja frecuencia, me imagino 2, 3.5, ¿no? Podría de repente repetir las maniobras porque dentro del espectro que hacemos es una de las articulaciones bien difíciles y por otro lado bien importantes demostrarla si hay proliferación sinovial. Por favor, le podría pedir que amplíe la técnica para la evaluación de la sacroiliaca.
Uhuau de estamba la yentatama sacroiliaquitama sandama albio inti se sinakata yokun anturi kolme pilko visi ja onko kuinka voisiko laajentaa tämä hankinostunut?
Okay, I think ultrasonography is not very reliable for detecting sacroiliitis. So we use MRI or other imaging models. But if you want to try it, it is about 10 megahertz probe, depending, of course, how thick, fat the patient is. And but as far as I have understood, there is not very much positive expectations for the use for diagnosing sacroiliitis.
¿Escuchan bien?
Sí, se escucha perfectamente.
Si algo pasó, bueno, no
importa. Yeah.
O sea, el doctor dice que no es tan confiable, no es tan confiable. En realidad, en la práctica no se usa mucho. Dependiendo de la contextura física del paciente, se puede utilizar una sonda de 10 megahertz, por ejemplo.
Yeah.
Pero no es muy confiable. Generalmente usamos más resonancia magnética.
Claro, claro. Para la evaluación de la articulación sacroiliaca es la clásica incidencia de Ferguson, ¿te acuerdas? Y luego la resonancia definitivamente. Pues, ¿no?
No, es porque obviamente la accesibilidad es un plano inclinado y hay muchas estructuras óseas que interfieren, ¿no? O sea, hay muchas, desde la espina ilíaca postero inferior, o sea, y está en un plano totalmente inclinado. Entonces eso hace prácticamente de que el primer agujero, el segundo puedan ser fácilmente identificables, pero digamos la punción no es tan confiable, ¿no?
Así es, así es. Ujú. Ahora la parte vascular, ¿no? La parte vascular, bueno, los radiólogos estamos muy identificados en la estructura, la evaluación vascular, ¿no? Tenemos un buen tiempo de experiencia en lo que es la parte vascular.
Y la
Y
como
sí,
son más mediciones, subtensión, ultrani.
Ok.
¿Ya?
ahora
Ustedes han tenido temporal, arteritis temporal. ¿Tienen ustedes cuántos
sí,
casos
sí,
por
sí.
año?
Justo el doctor Calvo es el que nos envía con cierta frecuencia, más que para descartar, ¿no? Buscar el signo del halo clásico que lo ha mostrado el doctor, hacemos la compresión, evaluamos la arteria temporal en toda su longitud, tanto en vista sagital, en vista axial, tal como lo ha demostrado el doctor, ¿no? Es un estudio fácil, accesible y muy importante, ¿no?
¿Ustedes encuentran casos positivos?
Hemos encontrado casos positivos, pero no tenemos una estadística, quizá el doctor Calvo, ¿no? Pero sí hemos encontrado casos, o sea, engrosamiento el clásico signo del halo que lo mostró el doctor, ¿no?
Ja perussamme que on muutamia tapauksia. Hänen pystyy kerro tilastollisesti kuinka monta tapauksia on, mutta kuitenkin heillä on ollut myöskin temporaaliarteriitti.
Muy bien.
Sí, nosotros acá, ¿qué te digo? Acá, digamos, es común, es muy común. Por ejemplo, en el hospital universitario, cuando yo hice la residencia, el paciente iba al oftalmólogo, ¿no? O sea, iba al oftalmólogo y el oftalmólogo es el que más o menos inclinaba el diagnóstico. Obviamente es un cuadro clínico típico, más la velocidad de sedimentación globular elevada, ¿no es cierto? Entonces, en el hospital universitario iba al oftalmólogo, pero aquí en nuestro hospital el paciente viene al reumatólogo. Entonces, nosotros hemos concentrado, digamos, gracias a Yuhani, que prácticamente somos 4 reumatólogos que evaluamos, ¿no? O sea, antes de iniciar el tratamiento con prednisolón o con solumedrol, entonces hacemos la evaluación, ¿no? Entonces, más o menos, la mayoría, muchos de los pacientes van de todas maneras a la biopsia y nosotros tenemos la chance de hacer la correlación. Y algo bien interesante, ¿no? Por ejemplo, el caso, por ejemplo, el doctor Yugani ha hablado de la zona occipital, o sea, pacientes que acusan una cefalea, digamos, en la zona occipital. El doctor Yugani ha encontrado el signo del halo en pequeñas arterias de la zona occipital, donde, digamos, la resonancia magnética, la tomografía aguda, ha encontrado signos inespecíficos, ¿no? Y acá, digamos, lo hemos encontrado con más claridad.
Sí, definitivamente el ultrasonido es un método versátil, importante, y en estos tiempos, ¿no? Lo que dijo el doctor Calvo y lo que hemos estado comentando, ¿no? Se tiene que trabajar en grupo, en equipo.
Sí.
Definitivamente el ultrasonido ha crecido tanto que es un estetoscopio más, es un método sumamente importante. El radiólogo tiene otros elementos añadidos. Estamos viendo radiografías, estamos viendo resonancias, estamos viendo ultrasonido vascular, en algunos todavía hacemos ginecobstetricia, ¿no? Entonces, pero hacia lo que vamos, ¿no? Con el ejemplo de ustedes, que son un país desarrollado, es trabajar en conjunto y definitivamente el clínico tiene que empezar a mover el transductor, es importante, es sumamente importante.
Nosotros no somos radiólogos, o sea, hemos aprendido, digamos, todos los principios de la ecografía, los principios físicos y los sesgos que pudieran existir, digamos, por ensayo y error, ¿no? Entonces,
Claro.
hasta convertirse en nuestro instrumento de trabajo cotidiano.
Por supuesto. Para nuestro medio, acá hay varios radiólogos, ¿no? Y nosotros recibimos a los pacientes que nos refieren los reumatólogos, ¿no? Para nuestro medio. Yo quisiera, por favor, dile al doctor Yuhani, porque nosotros hacemos un informe radiológico. El informe radiológico es un documento sumamente importante, ¿no? Es un documento, para empezar, médico legal.
Claro.
¿No? Médico legal. Segundo, es un documento donde debemos detallar todos nuestros hallazgos. Al final, una conclusión o impresión diagnóstica bien detallada para ubicar al clínico, ¿no? Y si es pertinente, si estamos en el hospital, como el caso con el grupo de reumatología de Cayetano, trabajamos conjuntamente. Ellos nos traen los pacientes y lo evaluamos conjuntamente, ¿no? Los residentes rotan con nosotros, ¿no? Y luego ellos van, de acuerdo a sus necesidades, van haciendo especialidades con grupos de reumatólogos extranjeros generalmente, ¿no? Entonces, ¿qué le recomendaría a los radiólogos, por favor, cuando hagan un informe acá para nuestro medio? ¿Le puede decir al doctor? Gracias.
Son periodistas que la gente rota gente que la asunto son yo con la mayoría de dama hacia aquí ya no son ya yo que muta sanota kaiki radiologi residenti te que valila te que testo y tata reumatologi in cansa son eligai reumatologi yudensa tario yo kupotila ya Cesar que son mica sosituxia sina anti-sigele tama sondama lausun sondama musculoesqueletinen tama lausunto mukaan entidad ellos epaselva kysymyks.
Well, I think that it's always good to have friendship with radiologists and rheumatologists. So this is the I have been in the business for 30 years, and it's always very important that there is friendship between, and we can learn from each other to make cooperation.
O sea, él habla de una colaboración estrecha, ¿no? Entre los dos grupos, entre radiólogos y reumatólogos.
Perfecto. Muy bien. Como te repito, Jesús, ha sido una espléndida mañana para nosotros, ya es tarde, noche para ustedes. Nuestro agradecimiento a ti, Jesús, por habernos permitido conocer y contactar con el doctor Yuhani. Al doctor Yuhani por sus excelentes charlas, ¿no? Han sido muy técnicas, muy importantes, ¿no? Y nos despedimos hasta el día de mañana. Mañana estamos con otros tópicos muy importantes y nuestro agradecimiento eterno, Jesús. Un abrazo.
Un abrazo y a todo el auditorio también, que tengan un lindo día y nos vemos el día de mañana.
Thank you very much, Dr. Yuhani. See you tomorrow.
Thank you very much. It was a pleasure to join the meeting and talk. Thank you.
Thank you.
See you tomorrow.
See you tomorrow.
Okay.
Bye-bye.
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 Bye-bye.